Welcome to one of our talks within our neurocritical care series, this one on the management of subdural hematoma, in which we comprehensively review both the medical and surgical management of this entity. Thanks for watching, and thanks for learning with us.
Medical Specialists Associates, making medical education more accessible.
Hello, my name is Dr. Kaushal, and today I'm going to be talking to you about the most common traumatic intracranial lesion, the subdural hematoma. There are three types: acute, subacute, and chronic. SDH is a closed head injury. This is due to a linear translation acceleration along the diameter of the skull in the lateral direction. This most commonly involves a bridging vein within the meninges, which is located at the surface of the skull. When this vein ruptures, it causes a buildup of blood between the brain and the tough outer lining. This is below the dura mater and above the arachnoid. This area is referred to as a subdural space. This also involves the arteries and the brain parenchyma. Acute SDH is reported between 5 to 25% with severe head injuries. This is also associated with cerebral contusions, which are small scattered bleeding in the surface of the brain, most commonly in the frontal and the temporal lobes. Acute SDH occurs within the first hour or less than 72 hours. It's a rapid blood accumulation and increase of intracranial pressures. Early symptoms will be temporary loss of consciousness, paralysis, or death. Late symptoms tend to be headaches, nausea, vomiting, slurred speech or unable to speak, confused, dizzy, numbness, and seizures. Subacute SDH occurs between 4 to 21 days. Chronic SDH has been reported between 1 to 5 cases per 100,000 population. This occurs later, mostly after 3 weeks, which is more than 21 days, or it can just occur within months. This is most commonly seen in older patients, and many of these patients will come to the ED resembling a stroke, possible brain tumors, or signs of dementia with gradual memory loss and personality changes. Chronic SDH has been diagnosed more recently, and that's due to better imaging. So the most common cause of SDH is head trauma. And the majority of these cases are going to involve a motor vehicle accident, a fall, assault. Patients with increased risk for subdural hematoma are patients that are on any antithrombotic agents like low-dose aspirin, Plavix, any anticoagulants, vitamin K antagonists. Also, patients that are going through hemodialysis are also increased risk. The highest risk patients are the patients with a significant cerebral atrophy, which we normally see in elderly patients, patients with history of chronic alcohol abuse, or previous traumatic brain injury. This is commonly seen in patients that are in the age between 31 to 47 and tend to be more men than women. There are also rare incidences like subarachnoid hemorrhages, dural metastasis, aneurysmal ruptures, AV malformations. The one thing you have to understand is many of your patients are going to come unable to recall any head trauma. This past month, I had 4 patients, and none of them could tell me a timeline of an incident of any possible head trauma. My patients ranged between ages of 51 to 81 years old. I had a 51-year-old female who came in with global aphasia. I had to get her history from her mother, who told me that she called the place that her daughter worked at to see if there was any fall or some sort of traumatic event. And all she could find out was from her colleagues was that yesterday she was acting very weird and she had slurred speech. And then when she came home, she told her mother that she just had a very bad headache, which she thought she had a migraine headache, and took a fear set, went to bed, woke up in the morning and was unable to speak, unable to express herself. She was able to comprehend what was happening in the room, but she wasn't able to communicate with us. I had another patient who was about 71 years old who just had headaches for a few months, went to her primary care physician, got a CT done, and it showed that she had a SDH and also a midline shift. Another patient I had was about 81 years old male. He had a chronic subdural hematoma, and he came in with signs of gradual memory loss. And he was also unable to speak, and his personality had changed, and that this was according to what his rehab nurses told us. The most interesting case I had was actually a 78-year-old male who came into the hospital with chest pain. He actually had a STEMI, and he was sent to the cath lab. And while they were putting a stent in, he coded. I was in the ICU at this time, so my colleagues and myself went to the code, started chest compressions and ACLS. After 15 minutes, the epinephrine hit, and this guy, I mean, he was a big guy, so this guy jolted out of the table like the Hulk, and literally everybody and anybody that was in that room jumped in and tried to put him down back onto the table. What had happened was that his head had toppled off the cath lab. So while we were doing chest compressions, his head was moving, very loosely. So we had to get a board and stick it under to stabilize his head. I mean, it wasn't great, but it helped out. What ended up happening was when he came to the ICU, he was connected to the impella. He had fixed dilated pupils. We were questioning if he had anoxic brain injury. Because he was connected to the impella, we weren't able to do a CT or an MRI. But once he was off of it and we were able to do imaging, we did notice that he had a subdural hematoma. Side note, he was also on IV heparin for DVT prophylaxis. So we had to take him off the heparin and let the hematoma settle down. And within a week, he was starting to express himself. He had multiple other issues going on, but we figured out that he actually did not have anoxic brain injury. Patients have reported coming in after seizures with subdural hematomas. I've read some reports, but not many. The most interesting report that I read recently was patients having subdural hematomas after a lumbar puncture. And this is caused by a sudden decrease in their intracranial pressure due to the CSF leakage. The sudden caudal shift of the brain causes a traction on the arachnoid motor and the venous structure, and this will lead to bleeding from the ruptured veins. So the first imaging that we always do is a CT scan. It is fast, it's simple, it's widely available. It gives us all the answers that we need right there at the moment to take the next steps that need to be taken. Acute subdural hemorrhages tend to be bright. They're crescent shaped. All subdural hematomas are crescent shaped because it crosses the suture lines. So like I said, the acute subdural hemorrhage will have more of a bright crescent shaped. The only time that you will not see a bright crescent shape, and it's going to be more dark, kind of dark like the chronic subdural hematoma, is with patients that have low hemoglobin and platelets. And most commonly we see patients with sickle cell disease that have this. Subacute and chronic tend to look very similar in the CT. They're very dark, hypodense. Sometimes with subacute, you will see a mixture of it, so it'll kind of look like it's in between. But the most sensitive test, actually, before I go further, I thought this was a great picture. This is just a great picture of what a midline shift looks like. As you can see, how the center is moved a little bit, and the hematoma. So now the most sensitive imaging is the MRI. The MRI is great because it gives us all the additional information that we need regarding the presence and the extent of any interparenchymal injuries that might be involved. Also, if there's any secondary causes. It also detects any small SDHs that we have missed from the CT scans. We use a type of sequence called FLAIR. It's fluid attenuation inversion recovery. And what it does is that it eliminates the CSF. So there's no CSF fluids. It can actually give us a great identification of what phase the hematoma might be in. So like I said earlier, many of your patients won't be able to recall trauma or give you a timeline. So here we can actually have a pretty good timeline of what the age of the hematoma might be. If it's early phase, if it's between 3 to 7 days, it'll show us in a subacute phase. Just like I said, it kind of with the colors, with subacute, it's going to be a bit of a mixture. If it's acute, it's going to be brighter. And then it can also tell us if it's a late subacute phase, which usually occurs around the 3rd week. This can also tell us if there's any associations with infarctions or subarachnoid hemorrhages. Another neuroimaging that we use that we don't initially do it on all the patients, but if we still are uncertain and we want to evaluate any possible underlying vascular lesions, we'll do it angiography. The first one we'll do is a non-invasive angiography. And if we don't get the answers that we need and we're still suspicious about any vascular lesions, then we will do a conventional angiography. And this is when we go and puncture your femoral artery in the groin, add a thin catheter, let me rephrase that. Put a thin catheter and go into the carotid or the vertebral arteries, add the dye, and see if we can get a better image of any vascular lesions that can be possibly causing this. So before we can make a judgment call on if this patient needs to go to surgery or not, we have to evaluate the prognosis. And this is done by, certain criteria that we need to follow. One is age. If you're more than 65 years old, you have a higher mortality rate. We have to assess the neurological status with the Glasgow Coma Scale, which are 3 categories of responsiveness: best eye opening, best verbal, best motor response, and the scores are between 3 to 15. If your scores are above 7, you have a lower mortality rate. Now, if your score is between 4 to 6 and you are over 65 years old, there's an 82% mortality rate versus a patient that's between 19 to 40 years of age, you have a 50% mortality rate. And if your score is less than 3, this is just not a good sign. It's a very poor prognosis. Another thing that we evaluate is the pupillary signs. Now, your pupils in the dark are between 4 to 8 millimeters. And then when there's a light flashed onto it, it's between 2 to 4 millimeters. So we're looking for any abnormal pupillary lights, any non-reactive pupils, any fixed or dilated pupils, or any asymmetry. Going back to my case with a patient, which we did chest compressions on, when he came to the ICU, the first thing we noticed was his fixed dilated pupils. But once again, because we were doing chest compressions for 80 minutes, we thought that it could be possibly an anoxic brain injury, but it turned out that it was a subdural hematoma. We also subjectively evaluate the patient. Are they clinically stable? Are they deteriorating as the time is going by? So there's multiple things that we need to consider before we can make a judgment call. We also need to see what's the presence and severity of other comorbidities that they might have, or other things that were associated with the trauma. So non-operative management, we generally put everybody on a seizure prophylaxis with Keppra 500 milligrams BID until the hematoma has resolved. And this is with the operation and without the operation. Or at least, let me rephrase that. Before they go into the operation, we put everybody into a seizure prophylaxis. People that will not be considered for operation are patients that are clinically stable, their clot thickness is less than 10 millimeters, or their midline shift is less than 5 millimeters. There's no signs of elevated intracranial pressures. Now, mind you, we will have to observe them for the next 48 hours. That's because a lot of times, many of these patients might require surgery within the hour or within the week after the injury. So the first 36 hours when the patient is with us, we're going to do Q1 neurological exams. We're going to monitor their intracranial pressures. Usually we do this for patients with a Glasgow Coma Scale score of less than 9. And we'll do serial brain CT imagings within the first 36 hours. There is a high incidence of clot expansion between this time period. So it's very, very crucial that we keep a close eye on these patients. Surgical management in acute SDH, it's an emergent surgery. We got to do the surgery between 2 to 4 hours after the onset of neurological deterioration, which will help lower the mortality rate. We also do surgical management in patients with clot thickness of over 10 millimeters or a midline shift of over 5 millimeters. Also, if their Glasgow Coma score changes from the initial assessment with decreased by 2 or more. If their intracranial pressure is more than 20, and also if their symptoms haven't resolved. For instance, my 51-year-old female, her global aphasia was not resolving within the first 36 hours she was with us. And so she did end up going to go get a craniotomy. And craniotomy is actually the most recommended procedure that we do for SDH. Chronic SDH, it's a surgical, it's an urgent surgical hematoma evacuation. And we usually do these in patients that have like a clot thickness of more than 10 millimeters, or if there's a midline shift. Also, if there's any signs of elevated intracranial pressures or brain herniation. So like I said, the most common and the best outcome technique we use is a craniotomy. And this is where we surgically slice off a section of the bone and remove it temporarily, which is known as a bone flap. And we'll get, we will suction and irrigate the hematoma very gently and then place the flap back. Another technique that is used, and I've only seen it used in severely affected patients where their Glasgow Coma score was between 4 to 6, or they had chronic SDH, and it was just an emergency and we had to do it right there and then. And this is where the neurosurgeon will come in bedside and make 2 small holes to relieve the pressure on the brain. And you can place a catheter. It's called the Jackson-Pratt drain. You could actually put the drain there and then allow the blood, to be drained through the drains. And you can leave it in there for a few days and let it drain out, and then and then take it out. The only issue with this is that you have a higher chance of infections. You can have blood clots. There is a lot of times, a lot of patients will bleed more versus a craniotomy. Although we will put them on an antibiotic afterwards, you have less likely to have infection and blood clots and increase the bleeding. Another technique is called trephination, and this is a very ancient technique. I mean, this technique's been around for hundreds and hundreds of years, and we always see this in like horror movies, where they're like drilling the brain, and this helps alleviate the intracranial pressure. This is actually still used in rural areas here in America. But once again, you have an increased chance of infections, increased risk of bleeding, and blood clots. Decompressive craniotomy is a craniectomy. My bad. A decompressive craniectomy is when you're removing the part of the skull and just pretty much leaving it open. I mean, it's great for relieving the swelling of the brain, but end of the day, it's going to be open. So it's, high risk for infections and blood clots and other complications. Mortality rate is between 30 to 47% with emergent surgeries between 2 to 4 hours after the onset of neurological deteriorations. And mortality is 80 to 90% when the intervention is delayed beyond 2 to 4 hours. Thank you for taking the time to listen to my lecture. I hope this was very informative. Thank you. Take care.
Thank you so much for watching and learning with us today. If you're interested in taking this class for credit, or if you're interested in our other services, such as our direct clinical care services, please visit our website at www.med-specialist.net or click on the link in the description below. Also, make sure you subscribe to our channel to stay up to date on our most current content and educational opportunities.